There are 4 anticholinesterases you need to be able to talk about in the FRCA exams. Here is the terminal of your motor neuron, and it's got lots of vesicles full of acetylcholine. And here is the postsynaptic membrane on the muscle, and this gap, the synaptic cleft, is about 50 to 70 nanometers. You've got lots of acetylcholine receptors on the membrane here, and down in the clefts you have acetylcholinesterase, which is an enzyme that breaks the acetylcholine down. So we have acetylcholine receptor, acetylcholinesterase. The whole point of acetylcholinesterase is it allows the acetylcholine not only to be inactivated so you don't get constant muscle twitching, but it also allows it to be recycled back into choline, which can then go back into the presynaptic membrane and be reused in a new vesicle for another muscle contraction in the future. So anticholinesterases inhibit acetylcholinesterase. So if you think about the effects an anticholinesterase is going to have, it's going to inhibit acetylcholinesterase, so there's going to be a build-up of acetylcholine in the neuromuscular junction. So there's going to be more muscle contraction every time these vesicles are released as a result of a depolarization of the nerve. So every time you get a stimulus to the muscle, you're going to get more muscle contraction. So you think about when you might want that to happen. If you're lacking acetylcholine, you're not releasing enough acetylcholine on each depolarization, or if you've not got enough acetylcholine receptors, or for some reason those acetylcholine receptors aren't working. Those are all times you might want to use an anticholinesterase to boost your acetylcholine levels. Now, the first situation you might want more acetylcholine is myasthenia gravis, which is a condition whereby you produce antibodies that destroy your acetylcholine receptors. So if you've got fewer receptors, you're going to get less of a response, so you want more acetylcholine to induce more of a response and help with the muscle weakness that you see in myasthenia. And the first anticholinesterase we're going to use is for diagnosing myasthenia gravis, and we use edrophonium. Edrophonium is a very short-acting anticholinesterase, and it is used diagnostically to figure out if the person in front of you has got myasthenia gravis, because if you give edrophonium and you inhibit the acetylcholinesterase very briefly, what you will see is on repeated contractions their muscle weakness gets better. So if someone's weakness improves with edrophonium, that suggests they've got myasthenia gravis, and we call this the tensilon test, or the edrophonium test. And this is the first anticholinesterase you need to be able to talk about, and it's the shortest acting. We don't really use it for anything else other than the tensilon test because it's too short acting to be meaningfully useful. The other one used in myasthenia gravis is pyridostigmine. So this is like edrophonium, it works in the same way, but it lasts a lot longer. And so it gives you more meaningful improvement in muscle strength. And so people might take this multiple times a day to boost their muscle strength if they have myasthenia gravis. The next condition is when someone's been given a muscle relaxant or a neuromuscular blocking agent for their anesthesia, such as rocuronium. What this does is it simply comes and blocks the acetylcholine receptor, and it blocks it competitively, meaning if you put enough acetylcholine into the synaptic cleft, it will compete with the rocuronium, and you can undo that muscle relaxation and you can get that muscle contraction back. So at the end of surgery, if the muscle relaxation is still having an effect and they're still very weak, we will reverse that with something like neostigmine. And neostigmine is a medium-acting version of edrophonium and pyridostigmine. So it's not as long as pyridostigmine, it's longer than edrophonium, and it works in the same way. It inhibits acetylcholinesterase, produces a huge build-up of acetylcholine, which can then compete with the rocuronium at the acetylcholine receptor. Nowadays, we often use Sagamidex, which is a completely different molecule and simply mops up the rocuronium molecule, so that often gets used in place of neostigmine. But neostigmine is the classic reversal agent for rocuronium, used for muscle relaxation. The last class of anticholinesterases we're going to talk about is organophosphates. These are not really human medicines that you're going to use. These are usually problems that come in with a clinical picture that you need to treat. So organophosphates are used in insecticides and other pesticides, particularly in farming, and they have been used previously as nerve gas agents in chemical warfare. These produce a classic clinical syndrome that you need to be able to spot and then to treat. So you need to know about how they work. These are very lipid soluble, so they diffuse very easily through the skin. What these molecules do is they bind to and phosphorylate the acetylcholinesterase, and this irreversibly completely inactivates the molecule, means it can't break down acetylcholine, so you get a massive increase in the amount of acetylcholine. But because it's very lipid soluble, it goes everywhere in the body, and it's completely non-specific. So anywhere else that you have acetylcholinesterase, it's going to block that too. So that'll be in your brain, in your gut, all of your glands, in your bladder, in your eyes, in your muscles. So you get a very characteristic picture, and the acronym often used is SLUDGEM, and this stands for salivation, lacrimation, urination, defecation, increased GI motility, which kind of feeds into your defecation, emesis or vomiting, and meiosis or pupil constriction. So this clinical syndrome, if you're seeing all of these symptoms in a farmer who's been putting pesticide all over his farm, it's likely looking at an organophosphate overdose. Logically then, because organophosphates are anticholinesterases, and this is what the toxidrome looks like, this is also what you see if you give an overdose of any of the ones we've already talked about. So if you give someone neostigmine, it will give you all of these symptoms. So when you reverse rocuronium, you give neostigmine to reverse the rocuronium. However, the neostigmine is going to cause all of these symptoms as well. So to prevent the patient from waking up with all of these horrible symptoms, we also give an antimuscarinic to block the acetylcholine excess at all the other receptors. So we give glycopyrrolate, and that is why when you look at the little vial of reversal, it is a combination of neostigmine and glycopyrrolate. The neostigmine is doing the reversal of the rocuronium, but it's also going to cause all of these cholinergic side effects at all these other sites in the body, and we don't want that. So we're going to reverse the cholinergic side effects by blocking those cholinergic receptors, the muscarinic receptors, by giving glycopyrrolate. So if you're wondering why it comes as a vial with glycopyrrolate and neostigmine, that's why. To treat organophosphate poisoning, the agent you need to know is pralidoxime, and this promotes hydrolysis and then reactivation of the inhibited acetylcholinesterase molecules. If you can talk about that kind of level of detail, you're absolutely going to smash the exam. Everything we've talked about is in our primary FRCA toolkit, which you can find in the link in the description.